Bismillahirrahmanirrahim. Um, I'm Dr. Muhammad Arakzai, and today we will be talking about arterial blood gases. The objectives of this lecture are that you should know what, why do we do arterial blood gases, that is the applications, uh, procedure, how to do, how to conduct or withdraw blood for arterial blood gases, and last but not the least, very important is to know or to interpret arterial blood gases. It should be your main task. So the applications or the use of arterial blood gases is to document respiratory failure and to know its severity. Like ARDS is a condition, acute respiratory distress syndrome, which we classify on the basis of arterial blood gases. Similarly, while putting patients on ventilator, you need to be aware that you will be required to do arterial blood gases twice a day at least, uh, because they will help you decide when to take the patient off the ventilator, that is weaning off, what we call in our uh, medical terminologies. Similarly, assessment of acid-base balances in critical illnesses. They help you assess the critically ill patient. Uh, they are also important in deciding the treatment strategies in COPD patient, in which you need to do arterial blood gases before prescribing long-term oxygen therapy. In certain conditions, in certain patients, before operating them, you need to be aware of their arterial blood gases. So these are the few documented uses. There are many other uses, but just to be brief, these are enough for you that you should know how important the arterial blood gases are. So now, to be able to do arterial blood gases, you need to know that first, but as it is obvious from the name that arterial blood gases means that you'll draw blood from an artery. So most easiest and convenient one is a radial artery, like you can see in this picture. The physician is trying to attempt a radial tap. Radial artery is localized by first palpating it, and then with the help of a specialized syringe, you go slightly deeper because arteries are a bit deep than veins, and you draw blood for arterial blood gas analysis. You can use various arteries like radial, femoral, or brachial are commonly used to draw blood for arterial blood gases. So the procedures and precautions that you need to know before doing a radial tap. So ideally there are heparinized syringe, which means that the syringes are flushed with heparin and then emptied, uh, so that the blood doesn't clot. Uh, Similarly, usually a 3 cc syringe is used, and it should have greater than 50% of blood in it, and the syringes must be sealed immediately after sampling so that air bubbles doesn't enter the syringe. And lastly, they should be transported quickly via cold chain uh, to analyze ABGs instantly. And now you can see in this slide an ABG syringe. These are specialized arterial blood gases syringes with a disposable cap over it. So, and you can see the blood in it is an arterial blood. Arterial blood usually have a high pressure, so they will pull the plunger backward once you attempt a radial tap, and it will have a clearer blood than a venous blood. You can take venous blood also, but that will be then called as venous blood gas analysis. Ideal is arterial blood gas analysis. You should be aware of the technical errors that can occur if the size of syringe is not appropriate, the volume of the blood taken is not adequate, and if there are any air bubbles or the body temperature is very low or very high, they can affect the values of arterial blood gases. Similarly, white cell count, if it is too high or the patient has any sepsis, so it can affect arterial blood gases value that you should keep in your mind before interpreting arterial blood gas values. So first of all, in arterial blood gases is that you should know about hypoxemia. What is hypoxemia? It is usually decreased oxygen in your arterial blood. Normal value of uh, arterial blood oxygen is 95 to 100 millimeter of mercury. So in mild hypoxemia, the value will be 60 to 80, and in moderate it would be 40 to 60, and in severe it would be less than 40 millimeter of mercury. You should be aware of this PaO2. It is different from oxygen saturation that you usually note from the meters, handheld oximeters that physicians or the other technical staff, health technicians carry. So apart from the oxygen value, you should be aware of the normal value of the carbon dioxide in blood, which is 35 to 45 millimeter of mercury. Similarly, your normal pH value is between 7.35 to 7.45. Bicarbonate level, usually the machines they calculate the bicarbonate level on their own by using software. There are certain formulas, but you don't need to know all the formulas. You just note down the normal value of the bicarbonate, because this value will be important in interpretation of this normal value should know before interpreting arterial blood gases. Uh, Before moving on to abnormal values, I need to I want you to know that uh, if pH is below 7.35, it is called as acidosis. If it is above 7.45, it is called as alkalosis. Similarly, CO2, it is usually generated by your lungs, so it's a respiratory component. If it is greater than we have already discussed the normal values. If it is greater than 45 millimeter of mercury, it is respiratory acidosis. Similarly, if it is less than 35, so it is respiratory alkalosis. HCO3 is a metabolic component, and if it is less than 22, you say it's a metabolic acidosis, and if it is greater than 26, you say it's alkalosis. So you will say metabolic on the basis of HCO3 and respiratory on the basis of carbon dioxide. Regulation of acid-base balance is very important in your body. In a normal person, usually there are buffer system like a bicarbonate buffer system, a phosphate buffer system, and a protein buffer system in order to maintain the normal pH. And then there are two major organs that are contributing to your normal acid base balance values. So one is renal regulation and the other is respiratory regulation. Renal regulation usually is through either excretion of bicarbonate or regeneration of bicarbonate as required by the body. In respiratory regulation is by with the help of increasing ventilation. When the ventilation is increased, so what will happen? The carbon dioxide will decrease. If there is more acid H positive in the body, so ventilation will increase in order to decrease PaCO2 in the body. Similarly, if there is decreased acid in the body, so your ventilation will automatically decrease to increase the PaCO2 in your blood or body. So that's how the respiratory regulation occurs. And then the buffer system, which is which in acidic condition you can see. In acidic condition, what happens to H2CO3, that is broken down into CO2 and H2O, and they are excreted from the body. So CO2 is a acid, and that's how it compensates. And in case of alkalosis, the CO2 join the H2O2 to form a H2CO3, which is a weak acid. So that's how. You don't need to know further details. You should be aware that there are buffer systems in your body to compensate. Now, how long the response occurs, how much longer for the response, how much the time is taken by the response. So bicarbonate buffer system usually act in few seconds. It acts very quickly. The respiratory regulation, it starts within minutes, achieve a good response by 2 hours, but usually take 24 hours to complete. The longest one is renal compensation, which almost takes 5 to 7 days, but it starts initiated within few hours. So you should be aware of the time period. Now, this table is very important in order for you to know what values do you encounter in arterial blood gases. So first of all, when you see an ABG report, you will see pH. Second would be PCO2. Third would be PO2, and then bicarbonate value. Saturation, if you don't see it, it doesn't matter that much. We'll talk about anionic gap also, what briefly what it is and how it is calculated. And then this is base excess. Normal values are given in the table. pH should be normally between 7.35 and 7.45, and PCO2 should be 35 to 45. PO2 normally is up to 100. If it is 104, it means that supplemental oxygen is being given. And HCO3 is normally 22 to 26. Just forget this 30. It is 22 to 26, just as mentioned in the previous slides. Anionic gap is 8 to 16, usually milliequivalent per liter. And base excess usually is from +2 to -2. So next is step-by-step analysis of acid-base disorder. This is very important, the interpretation of arterial blood gases. So the first thing is that you look at the PO2. If it is less than 80 millimeter He in that arterial blood gas report, so it will mean that the patient is hypoxic. The patient has hypoxemia. That is the only thing that you can draw from PO2. The next thing is to look at the pH. So if it is less than 7.35, means less than 7.35, so it is acidosis obviously. If it is greater than 7.45, it is alkalosis. If it is, the value is between 7.35 and 7.45, so either it's a mixed disorder, or it's a normal patient, or the patient has fully compensated. The next thing that you look in arterial blood gases is PCO2. We have discussed previously that the normal value is between 35 to 45. So if the value is above 45 millimeter of mercury, it means that the patient has acidosis. But what type of acidosis? As PCO2 is an element of respiration, so you'll say it's a respiratory acidosis. If the value is less than 35, so you'd say alkalosis. And the type of alkalosis, you'd say it is respiratory alkalosis. Then the next thing that you see is bicarbonate levels. Bicarbonate is a metabolic component, so if its value is greater than 26, so you'll say that the patient has alkalosis. But what type of alkalosis? Since it is a metabolic component, so you will say metabolic alkalosis. And if it is less than 22, so you'd say acidosis. But what type of acidosis? Metabolic acidosis. So whenever HCO3 value you are interpreting on the basis of HCO3 value, you'll always use the term metabolic. And if you are interpreting on the basis of CO2, you will say respiratory. So sometimes you see this anionic gap in arterial blood gases. So how to calculate an arterial blood gases? It is usually by combining the two positive ions and subtracting them from two negative ions. So two positive ions which are important in your blood is sodium and potassium, and subtracting them from a combination of chloride and bicarbonate volume. Normal anionic gap is 8 to 16 milliequivalent per liter. It is important in certain conditions, in certain metabolic condition in which the anionic gap is increased. If you want to know those conditions in which anionic gap is increased, I can enumerate few of the conditions. Like you have heard of diabetes. There is a complication of diabetes which is called as diabetic ketoacidosis. So in that condition, the anionic gap will increase. Uh, and similarly, in uremia, when there is kidney failure and there is much uremia in the blood, so the gap will increase. In lactic acidosis, again the anionic gap is increased, and there are other conditions in which the anionic gap will be normal. Like in certain poisoning, the anionic gap will be normal. So that's how you differentiate the normal anionic gap metabolic acidosis and increased anionic gap metabolic acidosis or alkalosis. So that is the significance of anionic gap, that will help you know that whether which ion is being lost. Base excess is another term that you'll encounter in an arterial blood gas report when you see it clinically. Usually the range is from +2 to -2. It is an indicator of metabolic component, but if it is below, -2, you can see that it is metabolic acidemia or metabolic acidosis. It can reach up to -10 in metabolic acidosis, severe metabolic acidosis, and above +2 will mean that it is metabolic alkalosis. Compensation, it is again an important part of arterial blood gases analysis. That compensation doesn't usually return pH to normal. In simple disorders, like for you, it is important to first know the simple disorders. The PCO2 and HCO3 values go in same direction. Like if they fall, they'll fall in the same direction. If they increase, they'll increase in a same manner. And compensation will never overcorrect pH. Like it will not take the pH from acidic to basic. And lack of compensation in appropriate time, again it means that there is some other disorders also present. So I need you to focus a bit on this slide. First of all, you need to, without seeing this portion, you need to recognize that if HCO3 is decreased and pH is decreased, so it is metabolic acidosis. So what happened? What is the compensatory response in metabolic acidosis? That the PCO2 value will fall. You can see both arrows are pointing in downward direction, so they are moving in the same direction. Simple first degree acid base disorder, which is I want you to understand, is that both HCO3 and PCO2 value will move in one direction. In another case, in the second, you can see the pH is increased, so it is alkalosis, and HCO3 is increased, so it is a metabolic alkalosis. So in metabolic alkalosis, what will happen is the ventilation will decrease and PCO2 will increase. You can see again the HCO3 and PCO2 are moving in the same direction. Next is, you can see pH is decreased and so it is acidosis, and again PCO2 is increased, so it is respiratory acidosis. So in respiratory acidosis, the compensation is through by increasing the bicarbonate ions in the blood. So PCO2 and bicarbonate are increasing in the same direction, so it is a primary respiratory acidosis, a simple disorder, respiratory acidosis. In respiratory alkalosis, what happens is, again you can see the pH is increased, PCO2 is decreased. So the compensation occurs through decreasing HCO3 via kidney. So both are decreasing in the same direction. In a mixed acid-base disorder, what will happen is that the PCO2 and HCO3 will not move in the same direction. Rather, they will start moving in opposite direction. So that is a bit complicated. For now, you should just understand a few examples. I'll be going to give you a few examples so that you can understand more easily acid-base disorders. So I'll be giving you one example of not one but in fact three examples of compensation. So first look at the first example. So what do you interpret from this pH? If someone has just this pH value with you, so you'll say that you have got acidosis because the pH is less than 7.35. Now if we give you the further value of CO2, which is 50, so what type of acidosis does he have? He has acidosis, so you'll say it's a respiratory acidosis. It's a respiratory acidosis. Now HCO3 is also increased, but it's not a metabolic. It is not a metabolic alkalosis because the pH is in the direction of acid. So compensation has occurred through HCO3. That's why this HCO3 is increased. So both CO2 and HCO3 are rising in the same direction. So it is acidosis, is respiratory acidosis, and compensation has occurred. But what type of compensation it is? Either it is partial or full. So for that to decide, you again need to look at the pH. If the pH is in the normal range, like 7.35 to 7.45, so then you will say it's a full compensation. But in this case, it is 7.30, so it is partial compensation. So it's a partially compensated respiratory acidosis. This scenario is a partially compensated respiratory acidosis. Now look at the second example. Just by looking at the pH, you should know that it is alkalosis. So the next thing that you look at is CO2. So CO2 is increased. So what type of alkalosis it is? Now you look at the, since it can't be a respiratory alkalosis because the CO2 is 51, but HCO3 is a metabolic component. It is an acid. So this scenario is a metabolic alkalosis. Why CO2 is raised now in this case? Because the compensation is occurring through lungs. So CO2 is increased. So it is an alkalosis with compensation. It is which type of alkalosis? It is a metabolic alkalosis because pH is increased, so it is alkalosis. It can't be respiratory alkalosis because CO2 is an acid. Otherwise, CO2 would be raised. Uh, so it is a metabolic alkalosis with compensation through carbon dioxide. I hope you have understood this second example also. And now you need to know whether it's a full compensation or a partial compensation. So again, as I said in the previous slide, that the pH should be normal for a full compensation. In this case, it is not normal. So it is a partial compensated metabolic alkalosis. This is a bit complicated one. Now you can see you cannot decide on the basis of pH whether it's a alkalosis or acidosis. So you will there is a tricky condition in this case. So it is more near to the acidic end, like from 7.35 it is usually normal, but for the sake of understanding you need to know that it is more close to the acidic end. So let's assume it that it is a acidic thing. So CO2 is increased, so it is a respiratory type of acidosis. Again, HCO3 is also raised, so you will say that it is a respiratory acidosis with compensation through HCO3. Now, whether this compensation is partial or full, so you will say it's a full compensation. Body has tried to compensate it fully. I'm not going into further complicated acid-base disorders, like sometimes a two respiratory mixed metabolic and respiratory acidosis can coexist in certain disorder. For you people, for the time being, this is enough to understand the basis of arterial blood gases. If you want to know further, you can read books as well as you can watch videos on YouTube. They'll help you a lot in understanding further complicated acid-base scenarios. But for the time being, this is enough for you. I hope you have understood something from this lecture.